We are live.
A very good evening, everyone. Welcome to the iFocus series Refractive Surgery, Lecture 474. The topic for today is Post LASIK Ectasia Management. The moderator for the session today is Dr. Pranita ma'am. Ma'am has done her MBBS and received a gold medal. Also, the MD from AIMS, FRC Ophtha London, FRCS Glasgow, FICO Cornea, FAICO Refractive Surgery, DNB, and FICO. Currently, ma'am is an assistant professor at GNEC Maulana Azad Medical College, New Delhi. Ma'am is also the executive member of Delhi Ophthalmic Society. Previously, ma'am was the senior resident at AIMS Delhi, also an ex-faculty at Lady Hardinge Medical College, UCMS, and Center for Sight, New Delhi. Ma'am has published over 88 PubMed indexed publications and has authored one book and 27 book chapters. She has also received Best Scientific Paper Award in Keracon 2018 and ISCKRS 2019. Ma'am is also convener for Surgical Skill Transfer Course SSTC at AIOC 2023 and 24. Welcome, ma'am.
Thank you, Garvita, for that kind introduction. And with that, we'll move on to the introduction of our chairperson. The chairperson for our program today is none other than Dr. Somshila Murthy, ma'am, who has done her medical training from Mumbai. And she has also done a fellowship in cornea from the prestigious LV Prasad Institute, and in uveitis and ocular pathology as well from Dhoni Eye Institute in USA. Previously, she was a full-time faculty at LVPI for 22 years and headed the cornea services at the Hyderabad campus of LVPI. And currently, she is the medical director of the Shantilal Sanghvi Eye Institute in Mumbai, that is in collaboration with LVPI again. She has participated in over 20 clinical trials and numerous publications in over 200 scientific journals which are both national and international, and has made various presentations again at national and international meetings. She has received various prestigious awards from the AAO, Best Paper in Cataract, Best Paper Uveitis, and the Women Ophthalmic Society Leadership Award, and also Best Paper Awards in the USI meeting, Best Poster Awards and IRSI Gold Medal Award and the IGO Honor Award. She's a member of the scientific committee of the AIOS at present in her second term. And the speaker for today is Dr. Prateek Teotia, sir, who has done his post-graduation in ophthalmology from Gandhi Medical College in Bhopal. He has done an FICO from UK and FRCS Glasgow, and he has also done his fellowship in cornea and refractive from the prestigious LV Prasad Eye Hospital. Currently, he is a consultant in cornea, cataract, and refractive surgery at Center for Sight, New Delhi, and previously has also been associated with the
I think we lost the feed from Dr. Pranita.
Yes, sir.
Dr. Pranita, please.
Yes. As ma'am said, sir has been a previous consultant in cornea, cataract, and refractive surgery, also director at CL Gupta Eye Bank, Muradabad. Sir specializes in phacoemulsification, LASIK, PRK, ICL, penetrating keratoplasty, lamellar keratoplasty, including DMEC and DALC. Sir has been a recipient of various prizes in ophthalmology quiz, paper, and poster presentations in numerous conferences. So has also given lectures as an invited faculty at various ophthalmic meetings, both national and international. I welcome you, sir.
Thank you, Garvita.
Sir, I would like to invite you to share your screen, sir, for the class.
So, as we all know, refractive surgery is one of the most commonly performed surgeries these days. So, it is also important for us to understand the complications that can arise out of these surgeries. And I'm sure Prateek sir is the best person who's going to be talking about post-LASIK ectasia, because he is doing both refractive surgeries as well as corneal procedures. So, he's aware of the pros and cons of both, and he'll be highlighting all the valid points on this topic.
Thank you, Dr. Pranita. So, can you see my slides?
Yes, sir.
Okay. So, the topic of my today's presentation is post-LASIK ectasia management, and I'm working as senior consultant cornea cataract and refractive surgery with Center for Sight Group of Eye Hospital, New Delhi and Gurugram.
So you can make that full screen. So
Yes, I will just make it full screen. Can you see it now?
Yes, sir, it's
yes,
visible.
sir. Yes, sir.
Okay. So no financial disclosure to make. So iatrogenic corneal ectasia is a rare but one of the most feared complication by refractive surgeons, can occur after uneventful refractive surgery, first described in 1998 by Professor Theo. It can lead to vision impairment and morbidity, causing frustration and dissatisfaction for both patients and refractive surgeons. It's more common after LASIK, but can occur after post-SMILE, RK, and PRK, postulated to occur as a result of insufficient corneal thickness, exacerbation of pre-existing subclinical or clinical keratoconus by further weakening of the corneal structure, and/or development of genetically predetermined ectasia occurring years after refractive surgery. So typical presentation is progressive corneal thinning and steepening, usually inferiorly, with loss of uncorrected visual acuity. Often best corrected visual acuity is also reduced, associated with increased myopia and irregular astigmatism. Incidence reported in literature is 0.04% to 0.9%. Average time of onset is 15.3 months, can occur as early as 1 week, or may present years after LASIK surgery. Risk factors for post-LASIK ectasia: preoperative ectatic disease, which may also occur despite of normal topography, high myopia, where the ablation is more, young age, where the corneal rigidity is less, thin cornea, low residual stromal bed thickness. So conventionally, 250 micron is the cutoff for LASIK, but nowadays surgeon prefer 300 micron to reduce the incidence of iatrogenic ectasia. Excessive ablation, thick flap creation, so the residual bed is less if you accidentally get a thick flap. So in the picture on right hand side top, you can see that the flap is thick and leaving a very low residual bed. So in these cases, the chances of ectasia are higher. If multiple enhancement or retreatment are done, then again you are reducing the residual stromal bed. If the small optic zone is there, there is abnormal corneal rigidity. If the patient suffers from formifrostic keratoconus or develops PMCD years after doing LASIK surgery, then also ectasia can develop. Patients who have chronic eye rubbing or they suffer trauma after surgery can also develop iatrogenic ectasia. Increased levels of inflammatory mediators such as interleukin-6, TNF-alpha, and MMP9 in tears are associated with increased incidences of iatrogenic ectasia, and there may be undetermined factors. Various risk scoring systems have been developed. Among them, Rendelman scoring system is there, which depends upon topography, residual stromal bed thickness, age, central corneal thickness, and mean refractive spherical equivalent. So if the score is 0 to 2, then the patient has low risk of developing ectasia after refractive surgery. If the score is 3, then the patient is at moderate risk. If the score is 4 or more, then the patient is at high risk of developing ectasia. Another scoring system is percentage tissue altered. So it is calculated by flap thickness plus ablation depth upon central corneal thickness. So historically, residual stromal bed thickness has been considered for prevention of ectasia. The cutoff we usually consider for residual stromal bed thickness is 300 for safely performing LASIK. Anterior 40% stroma has more cohesive tensile strength than posterior stroma. So anterior cornea is stiff because of the oblique arrangement of lamellar fibers. And the posterior and mid cornea is weaker. So anterior 140 to 180 micron cornea is tough, and the posterior 320 to 360 micron cornea is slightly weaker. So changes induced by combination of the flap thickness and ablation depth have a significant impact on corneal biomechanical properties, and percentage tissue altered should not cross greater than 40%. So no scoring can fully eliminate the probability of ectasia, as we have seen in clinic, high false positive and high false negative with every scoring systems. So post-keratorefractive surgery ectasia still can happen if the patient is in safe scores. So a good preoperative comprehensive evaluation is necessary to rule out the possibility of developing ectasia in future. A comprehensive evaluation of both the anterior and posterior surfaces topographically and tomographically, as well as full pachymetry mapping of the cornea is important in establishing diagnosis of corneal ectatic disease and following its course. Isolated islands of elevation, anteriorly, posteriorly, or both, are often seen in ectatic corneas and can be a helpful sign of keratoconus and post-keratorefractive ectasia when generated by slit scanning systems or Schimflug imaging. Advanced tomographers such as slit scanning, such as OBSCAN, and based on Schimflug systems such as Pentacam, they give us elevation data, giving additional information in detecting subclinical keratoconus or formicrusty keratoconus. Bellin ambrosio display and corneal thickness spatial profile can eliminate the inherent accuracies of curvature-based measurements. Corneal hysteresis and corneal resistance factors, they are assumed to be altered to detect corneal ectasia at the subclinical or biomechanical stage. There is focal biomechanical failure in ectasia rather than a generalized weakening. Aura, Corvis ST, and Brillouin optical microscopy are promising technologies for the clinical evaluation of the biomechanical properties of the corneal tissue. Higher order aberrations of the anterior and posterior corneal surface, they are altered in keratoconus and have been evaluated as a means of detecting both clinical and subclinical disease. Changes in wavefront analysis, such as increasing of higher order aberrations, particularly vertical coma, spherical aberrations, and trefoil aberrations, may also be present in these patients. OCT has pachymetry mapping and epithelial mapping software, which is useful for keratoconus detection. Typical apical epithelial thinning with surrounding epithelial thickening give us classical donut-shaped maps, which is highly sensitive in detecting early keratoconus or ectasia. Anterior segment OCT can also be used to assess LASIK flap thickness and residual bed flap in cases of post-refractive ectasia. It is important to differentiate decentered ablation from progressive ectasia. In decentration, immediate results are poor. There is early inferior stiffening. There is no secondary decrease of visual acuity, no progression, and laser treatment may help. But in ectasia, immediate results are good. There is no early inferior stiffening, but there is secondary decrease of visual acuity. It shows progression with time, and laser retreatment may worsen the situation. Treatment options for ectasia after laser vision correction. First and foremost important is patient education. We should be able to differentiate patients of normal keratoconus with post-LASIK ectasia, because the demand of a post-LASIK ectasia patient, they are much more higher. That patient has undergone refractive surgery to get rid of glasses and contact lenses, and again we are offering them treatment with glasses and contact lenses to restore their vision. In early cases, glasses may be helpful. In moderate cases, contact lenses such as RGP, semi-scleral, scleral, and hybrid contact lenses can be useful for the patients. CXL can be performed to halt the progression of keratoconus. ICRS implantation may help in giving better uncorrected visual acuity. CXL plus treatment, combining treatment with CXL may be helpful in correcting the patient refractive errors. Phakic IOL can again improve the patient uncorrected visual acuity in cases of suitable patients, and in advanced cases, corneal transplantation such as full thickness penetrating keratoplasty or DALK may be required. So we can stop the progression of ectasia by collagen cross linkage and its modifications. And visual rehabilitation can be provided by contact lenses, Intex, and DALK and PK. So combination of different strategies may be required for final visual rehabilitation. So we can first stabilize the cone to prevent the progression of keratoconus by cross-linking. We can flatten the cone and reduce the refractive error by Intex or Kerr-ring or Bio-rings. And then we can correct the refractive error and aim at hematopias by ICL. And in advanced cases, we can choose between DOLC and PK. So collagen cross-linking first developed by Professor Theo at the University of Dresden in Germany. This procedure consists of photopolymerization of corneal stroma by combining riboflavin with UVA. It increases rigidity of corneal collagen and thus reduces the likelihood of further ectasia. C3R in using UVA light with riboflavin induces extra covalent bond between and within collagen fibers and between collagen and proteoglycans. So combination of UV radiation and photoactivation with riboflavin leads to production of oxygen-free radicals, which leads to formation of cross-links between CNH2 NH links in the collagen fibers, thereby stiffening the cornea. So we can do conventional cross-linking or accelerated cross-linking. Our experience has shown that conventional cross-linking with 3 milliwatt per centimeter square energy for 30-minute exposure is more helpful in halting the progression of keratoconus compared to accelerated cross-linking. But accelerated cross-linking with 10-minute exposure and 9 milliwatt per centimeter square is equally effective compared to the conventional cross-linking. So in post-LASIK ectasia, there is variable response to CXL compared to patients with the keratoconus because of biomechanical differences caused by the LASIK flap. Possible differences in the riboflavin diffusion rate in post-LASIK cornea, especially at the flap interface. Intrinsic pathophysiological differences between keratoconus and ectasia may all contribute to different response. So response is not as robust as in keratoconus patients. Intracorneal ring segments, they act as passive spacing agents which flatten the cornea. They are made up of PMMA. They are of different types such as Intex, Ferrara, Bio-ring. So they work by shortening the arc length of the cornea, thereby making the cornea flat. So it causes flattening on and in between the segment tips, and there is steepening along the segment body. As you reduce the diameter of the ring, the greater is the correction, and greater the thickness, the greater is the correction. So this is a video of Intex. Here, first we are creating the channels with the help of femtosecond laser. You can also create channels by manually operated surgical equipments, but femtosecond laser is more effective and more precise in creating the channel, leading to lesser complications. So here, after the patient is docked with suction ring, laser is fired, thereby giving us a circular ring of dissection. Usually the dissection is carried out at 70% depth, and then a vertical incision is made along the steepest axis. So this vertical incision is connected to the surface of the cornea. It is opened with a spatula, first by going vertically down, then along the superior axis, and then with the other end of the spatula, we open the channel by going in the similar way. So the Intex comes in the package like this, and then we hold the Intex with the forceps. So it is placed first vertically and then positioned along the superior axis because it is difficult to put Intex in the superior area. So first put the segment in the difficult direction, then you can place this segment in the inferior direction similarly. At the end of the surgery, we need to close the entry wound with 10-0 nylon suture. So we just place a 10-0 nylon suture and the knot is buried. So now we'll see a case of 31-year-old female, LASIK done 6 years back elsewhere, developed post-LASIK ectasia. Cross-linking done in 2010 and intakes performed in July 2010, and cross-linking was done in January 2010. So in this, the Kmax was 46.4 and refractive error was with minus 4.5 diopter and 2.5 cylinder. BCA was 6/60. After cross-linking, Kmax reduced to 45.4 and BCV improves to 6/36 with minus 3.5 dioptric cylinder and minus 3.5 diopter sphere and minus 1.5 dioptric cylinder. After intracorneal ring segment, Kmax reduced to 43.7 and BCVA improved to 6/9 with minus 1.25 diopter sphere and minus 1 diopter cylinder, and uncorrected visual acuity improved to 6/10. So this is pre-CXL and Intex map, and this is post-CXL and Intex map. Here we can see that the inferior steepening is corrected and the cornea has become more uniform after Intex and CXL. This is a Schimflug image with Intex showing the presence of Intex superiorly and inferiorly segment, and we can see that the Intex is in place. So whether we should do sequential CXL and ICRS or simultaneous CXL and ICRS, so this is a question. So CXL followed by ICRS, the progression is arrested by cross-linking, corneal rigidity improved, and corneal shape normalized by intracorneal ring segment later on. So mechanical flattening effect is less than predicted with ICRS, and delay of 6 to 8 months is there in getting final visual recovery. If we do simultaneous CXL and ICRS, there is maximal mechanical flattening effect with intracorneal ring segment, and further progression is arrested by CXL. It's more than a simple additive effect when done simultaneously. So why we get synergistic effect? There is increased biomechanical rigidity of CXL, altered pattern and distribution of collagen changes with intracorneal ring segments, and there is possible mechanism of increased riboflavin concentration between the intracorneal ring segment with increased collagen cross-linkage. So we will again see a case. So here the left eye at presentation, this is the case of a girl with post-LASIK ectasia. At presentation, mean K was 41.6 and left eye at presentation had minus 2 dioptric sphere with minus 2.25 dioptric cylinder with visual acuity of 6/9. So 2 years later, we saw that this case has progressed further with mean K increased to 44.3 and refractive error increased to minus 4 diopter with minus 1.25 and the visual acuity reduced to 6/9 parts. At this stage, cross-linking was done. And later on, we noticed that this case has progressed in pregnancy with the mean K increased to 47.1 diopter and refractive error increased to minus 6 diopter, spare and minus 1 cylinder, and the visual acuity reduced to 6/12. So despite cross-linking, this case progressed in pregnancy. So this was the left eye, and in right eye, the mean K was 40.9, and the refractive error was minus 3.5 dioptric spare with minus 1.5 dioptric cylinder with BCV of 6/9. So post CXL, mean K reduced to 38.9 diopter and visual acuity improved to 6/6 parts with refractive error of minus 2.5 diopter spare and minus 1 dioptric cylinder. And in pregnancy, the right eye remained stable or slightly better with the mean K remaining at 37.9 diopter. And right eye showed a visual acuity of 6/9 with plain minus 1 diopter spare. So what we learned from this case that ICRS is a useful treatment modality for post-LASIK ectasia, and prevention is always better than cure. So this is the slide which shows that the normal cornea has the strongest stroma anteriorly, and as we go down, that rigidity of corneal stroma also goes down. In PRK, we are treating only the superficial area, so the cornea remains uh, biomechanically stronger. In LASIK, we are creating a flap in the anterior stroma and ablating again the anterior stroma. So the strength of cornea goes down post LASIK. In SMILE, the anterior cornea is relatively spared, and then we are removing the lenticule, and the posterior stroma remains similar to LASIK. So PRK and SMILE, they are slightly biomechanical superior compared to LASIK. And role of extras, the combination of PRK, LASIK or SMILE with accelerated cross-linking has been practiced to prevent ectasia in moderate to high-risk cases with Randleman score greater than or 3, resulting in favorable outcomes. So relaxed SMILE or LASIK is performed using standard surgical techniques. 0.1 ml of saline-based riboflavin, which is 2.25%, is injected into the interface and allowed to diffuse for 60 seconds, followed by washing of the interface. UV radiation is performed with total energy exposure of 3.4 joules per centimeter square. So, is it necessary for all cases? No. The present indications are thin cornea if you are performing it for high myopia. There is family history of keratoconus. There is topographic asymmetry, difference in astigmatism between two eyes greater than 0.75 diopter, young patient, and it can be performed in hyperopes to prevent regression. So take home message from our topic is that careful screening is necessary before planning refractive surgery. PRK SMILE presumed to have reduced risk of ectasia due to better corneal biomechanics. New modalities of combining CXL with laser vision correction may be performed in moderate to high risk cases. And Intex plus CXL may still give a good uncorrected visual acuity after ectasia. Thank you for your patient listen.
Hi, Prateek. Somshila here.
Hello,
Very
ma'am.
excellent. Hi, excellent presentation as usual. So I just had, since you still have your screen on share mode, had
Yes, I will use
maybe
it.
I missed that. So if you can just go to the quad map for the patient which you had shown with post LASIK ectasia. So the previous one, the pre-operative map. So yeah, so this
This one
patient,
or this
the
one, ma'am?
next one, yeah, about the case,
This one, ma'am, or next one?
the next one.
Okay, ma'am. This
So
one?
this patient, yeah. So this
Yeah.
patient, you have history about this patient. Patient underwent surgery,
Yes.
and the right eye.
This is right, ma'am.
Okay. So the maps that you showed earlier of the same patient, and then how it progressed with time. Is
Yes,
that
yes,
what you're
yes.
showing?
Yes, ma'am.
So just two slides early, just two slides before this.
Yeah.
Yeah. So this one is when there was progression. Is that right? Of myopia or of
Yes,
the
yes. Patient was lost to follow-up and there was
yeah.
progression of myopia. At this stage, CXL was done, ma'am.
Yeah. Only thing, the map per se doesn't really reflect it doesn't really you can't rule in the diagnosis of ectasia with this map per se. You'll see that centrally, yeah, it is steep, and uh, mid peripheral is flat, but that does ectasia typically you'd see inferior. So it's
Yes,
very unusual, unless it's you could have, I mean, maybe the tangential map would have helped better. So on this map, I wouldn't have ruled it as ectasia. That wouldn't have been my diagnosis. Can you show the other eye, the right eye? Here in the right eye, you have, yeah. So pre-operative, before you did CXL with
yeah,
Intax,
this was
you have,
the map.
yeah. This is the post-operative, I'm guessing.
No, this is post CXL, ma'am.
This is
This is
okay. So okay. So
CXL.
one slide earlier is of the left eye.
Yes, that is during pregnancy
That's
that
right.
case
Yeah. So
progressed.
this is yeah. So this is suggesting progression. Yeah. This I agree.
Yes, yes.
But it is very unusual that in the previous map also centrally you had steep cornea,
Yeah,
post
but the
myopic.
refractive error increased, ma'am, in this case, no? So
Okay.
that's why we thought of progression. The previously the refractive error was -2, and in this the Kmax also increased from 41 Mean K increased from
Yeah.
41.6 to 44.3.
So 2 days ago, Himanshu took an excellent class
Yes, ma'am.
about all the causes of change in refractive error, especially myopic shift in patients who undergo refractive surgery. So if the same audience is listening, so they would remember those causes. And of course, this patient, the left eye progressed because the next map shows that there was further
Yeah.
steepening, which also goes inferior. So early ectasia always seems to occur inferiorly in the inferior one-thirds of the cornea. And I always look for early signs of early ectasia over there, even before the central cornea appears steeper and even before there is change. So at this point, the patient would come with fluctuation in vision. And when I do the pentacam or any other topographic imaging, so I look for the inferior cornea. And that's where you see the first signs of change in the keratometry. And that is first indication that you may be looking at ectasia. The second point I wanted to discuss or rather debate with you is about CXL with refractive surgery. I know that there are many surgeons who do it, but there is, so like you had quoted literature, cited literature for CXL with intracorneal rings, which seem to have an additive effect and a beneficial effect because you may have better post-operative visual acuity for the patient, lesser dependence on contact lens, and maybe see well with even with glasses. But in the case of in the case of combination of CXL with refractive surgery, so do you, in your literature search, come across any studies which actually describe it? Because some of your indications that you've put in of a difference between both eyes of 0.75, now that is very easy to happen.
Yes, but in borderline cases which have slightly irregular topography, in those cases you can perform it, not in all cases, ma'am. If so, we are not suggesting that you should do it,
Yeah. So you
but
have a
in,
slide.
yes,
If you can just go to
yes,
that
I
slide on
can, yes,
indications. So in that slide, you are actually suggesting that these are all
yes,
the indications, which
present
includes,
indications, yes, but
yeah, which includes difference in astigmatism between two eyes of more
yes,
than 0.75. Young patients, most of our refractive surgery are young patients. And so C3, refractive surgery with CXL, I'm not sure whether it prevents regression. There isn't anything published to my knowledge. There may be, but
in
at least
hyperovopes, it has been mentioned, ma'am, that it may prevent regression.
no. So what I'm saying is because our audience is a young audience and students.
Yes,
So if we have any of these indications, so I am arguing as a
yes,
debate, as an argument that but combining cross-linking with refractive surgery, in my mind, is not a solution, actually. I know many people do, many surgeons do it, very experienced surgeons also
yes,
are
they,
all for it, but there are also equal number of people who don't do it.
yes,
And
yes.
the reason, yeah, so it is not
Not mandatory. If the
not
patient
man,
is
yeah.
highly motivated and if you are correcting high myopias, then to be on legally safer, you can add cross-linking in these cases. I will not suggest that you should do it in all cases. Either you can uh, follow up the patient, or we are doing it in cases of borderline cases because the patient
Right.
cannot come back again for follow-up because they are traveling abroad. And in those cases, if the topography is slightly borderline, in those cases, we are
Right.
adding CXL along with the smile.
The incidence of post refractive surgery ectasia is actually very low,
Yes,
which
it's
is what we
lower.
had mentioned even
Yes,
2 days earlier when Himanshu took his class. And I had the same comment that post ectasia is actually very low. Or maybe we don't know it because all our patients don't come back. It's not 100% follow-up for
yes,
us.
yes.
But as per publications or as per whatever shared experience we have, it is low. And whatever shared literature search that you can do. So keeping that in mind, I think that the jury is out whether combining refractive surgery with cross-linking really benefits
It's
or
debatable. It's
is
debatable.
debatable. Yeah.
Yes,
So
yes.
that's, yeah. So I'm
So
just putting,
some surgeons, they are performing it. Maybe the institutes, they are still not doing it.
no. So some surgeons performed it and then stopped performing it also. So there's also that school of thought
Yes.
that maybe it's not necessary. Yeah.
To
So
treat,
it's very
yes,
hard to
yes,
answer the question. Yeah.
yes. So I
Ma'am,
would
I have
recommend
one
in
question.
borderline cases, you can do surface ablation, which is much safer.
So as you showed in a very beautiful slide and you explained very well
Yeah.
that the best way in which you can least disturb the anterior cornea is if you do surface ablation,
Yes, ma'am.
and then followed by if you do smile, corneal biomechanics a little better preserved. And of course, we all know that with LASIK, because of the flap that we are cutting, the weakening the cornea with the biomechanics, and also we are ablating at a deeper, more of the stroma, which has stronger inter collagen connections. So we are weakening the cornea further, so that by two hit mechanism, both the creation of the flap and by hitting the cornea, which is
Yeah.
more important for biomechanics stability. And that's why I don't think the post PRK there are reports of ectasia, whereas both post smile and LASIK you have reports of ectasia, because even in smile you have an anterior portion and only below that you're doing the ablation. So it's very similar to LASIK in that way. So this slide very beautifully shows if I have a patient who has thinner cornea, borderline pachymetry, so I would
Yeah.
always offer surface ablation. And rather than combining with cross-linking, I feel that when, if at all a patient happens to come back, we closely monitor these kind of at-risk patients, and then we offer cross-linking when we start seeing the trend towards ectasia, which I mentioned that the earliest sign could be that change in refractive error or unsatisfactory unsatisfactory vision. After having initial good vision, the vision becomes unsatisfactory, and you see that inferiorly the cornea is getting steeper at the inferior portion of the quad map. So those are evidences that the patient is probably in early ectasia. Sorry, Pranita, I cut
Yes,
you
ma'am.
off.
No, 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 ma'am. So, ma'am, I just wanted to on that discussion, I just wanted to ask one question to you, ma'am. Where you have a case of post LASIK ectasia, what is your standard protocol? Do you wait for progression before doing a CXL, or do you go for a CXL at the first go of the diagnosis of post LASIK ectasia?
Most of the time, these are if the history correlates that it is recent progression, then definitely I would go right away and cross-link for these patients. Of course, you might want to treat certain factors, like if you discover that there's allergy or something like that, you might
Mm,
also want to treat that. But because the patient may be an eye rubber and so on, which is why
mm,
they may have ectasia. But very few cases, sometimes the patients come to us, they are already had the ectasia and then they tell us that it's stable for a while.
mm,
So for a long while, then those cases I might wait. But I would say the majority of cases when they come, I don't wait for further progression. After eliciting a good history, which suggests a recent onset, I do go on and cross-link. Some ectasias, as I think Pratik also mentioned, are stationary. They don't progress. So also one more deciding factor could be vision. If the patient still has nearly excellent vision and has a history that this vision has been now stable. Earlier there was a fluctuation, now my vision is stabilized.
mm,
So the only time we do something is when we are planning a procedure to improve their uncorrected visual acuity or put them back into glasses from contact lenses if the cornea was so irregular. So
mm.
then it's post-LASIK ectasia. Yes, it is non-progressive, but we are doing a procedure for them to improve the vision. So like let us say intracorneal rings or whatever. So there we
Then you
also cross-link.
definitely like to couple.
Exactly, yeah.
Yes. Ma'am, do you also keep age as a cutoff to decide? Like a lot of patients are already, I have a patient who's on follow-up. She's already 39 years old.
Yeah,
She has post-LASIK ectasia, but it's remaining stable
exactly,
because of
yeah.
her age.
That's
Also,
right.
I wanted to follow her up.
Yeah,
But if the patient is young, so
that's
in
right.
that case, I think we would like to
Absolutely,
cross-link
yeah.
earlier.
Yeah, I'm on the same page as you are. Similarly.
Okay.
So in
Pratik, how
younger
do you
patient,
do?
how long we should wait, ma'am? At 3 months interval, we should take scans, or
Follow-ups.
would you do it
Yes, yes,
immediately?
I would do it earlier than what we do for, earlier days in ketoconus, we would, or say stable looking ketoconus, older patients, we would perhaps call them after 6 months. But when the patient first reports to us and says that now this has been stable for a while, maybe you have some old maps to match with, and you see that there is no change. So this is a stable patient with post-LASIK ectasia. So, but there I would still call them earlier initially for 3 months or 4 months and expect to see some change, because unlike a ketoconus progression, post-LASIK ectasia, there seems to be some inflammatory drive or stimulus, which is why there's progression, and this can be fairly rapid. In fact, you'll have a lot of patients with history of undergoing surgery in their 20s, early 20s, and they were doing very well for years. And then now they're just hitting late 20s or coming towards 30. And then they say that my vision began fluctuating for past couple of years. And then when they come to you, you notice that they have ectasia. So these patients also, it's a recent phenomenon for them. So then we do cross-link, offer cross-linking without waiting. Do you do anything different, Prateek?
No, ma'am. In post-LASIK ectasia, as soon as I diagnose, I cross-link.
Yeah.
Because sometimes the patient get lost, and when they come up,
Yeah, we
the
have
condition has progressed too
I
much.
that's right. So those
Same is with
conditions, I mean, we
keratoconus
have
also.
to.
In younger patient, I cross-link them as soon as I diagnose them.
That's right. So our follow-ups has been always been challenging
Yes,
that many patients will not follow up.
yes.
So the risk versus benefit is what we're looking at. So can we risk waiting and the patient has further progression and further drop in the visual acuity at least, and difficulty in correcting that visual acuity with just glasses, or then they have to go on to more and more highly specialized contact lens wear, which is very difficult and not a long-term solution for anyone in life.
So I was following up a case of keratoconus, young patient. Since last 3 years, it remained stable. And now, after fourth year, it showed progression. So now I have cross-linked that case. I was following up that case, but it was the patient was carrying 2 or 3 scans which were stable. So I kept on following that patient, asked him not to do any eye rubbing.
Yes.
And for 3 years, the patient remains stable. Now in fourth year, now the keratoconus is progressing. And
So
it could be
unpredictable
associated with,
period.
yes, because now he has started studying in colleges and more use of laptop, and maybe he has again started doing eye rubbing.
Yeah.
Mm. So I
You
think
were
Garvita
asking one
will.
question, ma'am. Dr. Somshila, you were asking something from me?
No, I wasn't. I was just agreeing with you
Okay.
that sometimes we can't have a one size fits all,
Yes, yes,
and yeah, we do
yes.
have some.
So,
We can have.
all patients, they behave differently, ma'am.
True.
Yes. So, but we do have groups in which we can divide our patients. Very young patients in their teens and
Yes,
so on. It's sort of an upfront cross-linking. The only thing is, of course, control the allergy if they have allergy. So control allergy like anything, and then go ahead and cross-link. Patients in their 20s, unless if the vision is, 20/20 with sort of
yes,
great
yes,
vision. So there I
yes,
might want to wait. But
yes.
otherwise, even patients in their 20s, I usually take them up. In my mind, I think that I will be doing cross-linking, but I may not tell it at the first visit. I might wait and have a buy-in from the patient and, of course, treat allergy and so on. Patient, on the other hand, is heading towards 30s, already crossed 30. There I'm a little more conservative and I might wait and review the patient and see if it's progressing and then offer cross-linking.
Just one more thing. Considering that we all do understand the concept that there are some inflammatory mediators involved in this whole process of post-LASIK ectasia. So, do
Yes.
you also keep the patient on some topical immunomodulators for prolonged course in these patients?
I have done both actually. So initial part, before we had a lot of information about the inflammatory drive, so we would never use anything beyond perioperative low dose topical steroids and then lubricants. But afterwards, there was some evidence in publications which suggested that the tear film has several chemical agents, including cytokines, which inflammatory mediators, which keep driving this inflammation and keep on perpetuating the cornea to behave the way it behaves. It activates the keratocytes. So subsequently, I did start patients on long-term, especially cyclosporin, which is fairly safe drug, except for the topical side effect of stinging that it does. Because the numbers are small, Pranita, so post-LASIK ectasia, each of us in our own hands, hopefully, zero. We would like to keep it zero, but collectively we would have treated patients across, especially in larger practices. So there's small numbers. So it's very hard to say whether these agents actually
Really work.
work or help in prolonging or help in keeping the
Retarding the
patients
process.
retarding the process or anything. whether it works. In other words, does it have any role to play or not?
Okay. I think we've had a very useful discussion. Garvita, are there any other questions from that we would further like to discuss?
Yes, ma'am. We have three questions from our DNB student. First is, if the patient worsens post C3R, how to plan the secondary procedure?
That's for Prateek.
Post C3R, the patient has worsened. How to plan the okay.
Secondary procedure.
So we would like to wait first for 3 to 6 months, okay, to see whether the condition is stable or not. If the patient is progressing further, then we would like to study the bed, how much bed is there. If there is adequate bed, then we may do repeat the procedure, maybe considering that the first procedure was not that effective. I have not treated post C3R progression. Ma'am, do you have any?
Repeat CXL in literature has been reported for
Yes, it has
keratoconus.
been reported, but I
Yes,
have
but
not.
the
experienced.
efficacy, I think, is only 30 to 40% compared to the primary CXL working in almost 50 to 60% cases. Ma'am, any expert comments from your side, ma'am?
No, just to say that again, as Prateek pointed out, that the number of cases each of us may, none of us may have handled volumes of cases. So the small pool that we have, we may not have really, though it is, we know that the efficacy of CXL is lower in post LASIK or post refractive surgery ectasia, but we still do it. And I think majority of cases we do have success. I just want to qualify that when we say that there is progression, as all of us here in this group know, that you have to be very sure that what you're talking about is true progression and not just taking a 3-month data or something like that. You have to wait for adequate time before you call it progression and the definite signs, basically including the refractive error, the topography, and so on, which will tell us that it's a failure of the first cross-linking. And if it is, I guess most of us here would agree that we can definitely, if there is still scope to repeat a cross-linking, definitely we can repeat it for a second time, just like how we do in keratoconus patients, where either the effect of the first cross-linking wears off as the child grows older, or they have progression once again. So we do repeat cross-linking, though it's rare. So the answer is we can repeat cross-linking if we're very, very sure that it has progressed. But if we should be ready that we may not face success even a second time. So ectasia is not something that ultimately there'll be corneal perforation and thinning and melt. That is not ectasia. Ultimately, it will stabilize at some point on its own, and the patient will be left behind with a refractive error, which may not be correctable, or you might have to use scleral contact lens. We'll have to discuss surgical procedures like corneal transplantation, talc, and so on for these patients ultimately.
Right, ma'am. There's also another question related to that. If we do only C3R, how closely should we follow up the patient and repeat pentacam?
Again,
Prateek,
Prateek, it's for you.
Can you repeat the question?
If we do C3R, how closely should we follow up the patient and repeat pentacam?
At least after 3 months, and then 6 monthly, we can repeat the pentacam.
Okay.
It is also important for the students to understand that when they are looking at the serial pentacams post CXL, the thickness is bound to decrease post CXL by say at least 30 to 40 microns, and that is not suggestive of progression,
Progression,
because
yes.
that is a compaction of the tissue that is happening. So you have to look at all the parameters. Initial first two scans will definitely show a drop in CCT, the thinnest pachymetry, but it is the keratometry, Kmax, K1, K2 is what we have to actually look when we're talking about post CXL progression.
So thickness will reduce post CXL. It will, because the cornea will become more compact, and it is not suggestive of progression. So as rightly suggested by Dr. Panita, we should look after other parameters such as Kmax, K1, K2, and topographic maps, whether they are flattening compared to the previous visits. So thickness is not suggestive of progression, and but it is suggestive of good cross-linking effect.
Right, sir. Last question. Please explain the role of PRK, PTK plus cross-linking in ectasia. What is the minimum corneal thickness required to plan, and can a subtractive procedure further weaken the cornea?
I have not done this, but studies are suggesting that you can, if the corneal thickness is more than 500, then you can do PTK followed by PRK up to a level of 50 micron to correct the refractive errors and do the cross-linking. But this is suitable only for cases which have good corneal thickness. We do not see such kind of cases.
Okay, sir. Those are all the questions that I had.
Dr. Somshila, would you like to answer this question? PTK followed by PRK with CXL?
I completely agree with you. I think when they meant PRK, PTK, probably they meant like a transepithelial PRK or
Yes,
something.
yes.
Okay, okay.
Yeah. So I completely agree. We never get. It means that the patient may have had 600 micron cornea,
Yes, yes. We
then
do
had
not see
refractive
such kind.
surgery. But then in that case, with such a thick cornea, why should they get ectasia? So so it's a good question. Probably if we have adequate, just like what we follow for keratoconus, similarly we can consider. You've answered that question that up to 50 microns, you might do a little refractive error correction also, whatever we can get in. But in post-LASIK ectasia, we won't have that adequate thickness to do those corrections.
Maybe in Western world where the thickness is more, they would be seeing such kind of cases. In our scenario, we hardly see patients with 580, 590 thickness. Mostly the thickness would be around 530, 540, most cases. Very
Yeah,
rarely we see
yeah.
patient with
You're talking about prior to refractive
prior to
surgery.
refractive surgery.
Yeah.
Yes.
In the region where I practice in South in Hyderabad areas, whoever the patients come to us, our average pachymetry is 500. So therefore, we end up doing surface ablation a lot. In
Yes.
More
fact,
PRKs.
if I get a 550 pachymetry, we might just open up a bottle of champagne or something. It's like that.
So most cases are 530, 520, Very rarely we get 570, 580.
Okay.
Those were all the questions. Thank you, sir. Thank you, ma'am.
Thank you, Dr. Somshila.
Thank you, Prateek. I apologize about my cellular connection, but it was wonderful listening to you, Prateek. I think you took an excellent, crisp presentation and managed to cover all the important points and with great case examples also, including surgery.
Thank you,
Thank you for
ma'am.
that.
Thank you, ma'am. Thank you, Dr. Pranita.
Thank you, sir. Thank you, Somshila ma'am, and thank you, Garvita. So I think it has been an excellent lecture. So
Thank you,
with that,
Pranita,
yes, thank
Thank you,
you.
ma'am.
for
Thank
moderating
you,
the
sir.
session. Though probably you could chair this session, I'm sure.
No, ma'am, not in front of you, ma'am, never.
That's why I didn't put my camera on. Thank you. Thank you, Garvita, also.
Thank you.
Thank you.
Thank you.
Okay.